Good afternoon, good evening, and welcome all to today's discussion on aortic regurgitation. And thanks Axis Medical School for giving me opportunity to talk on aortic regurgitation. So today we'll discuss on the valvular heart disease. It's aortic regurgitation, that is regurgitation of the aortic valve. And we'll discuss what is aortic regurgitation, how we can diagnose with aortic regurgitation, and how a patient presents with aortic regurgitation, and how to will be the treatment of a patient presented with aortic regurgitation. And the discussion will obviously on case-based and evidence-based. So let us move forward. Now, this is a case of a patient with aortic regurgitation. A 53-year-old gentleman presented with shortness of breath on exertion for last 2 years, increasing in intensity for the last 3 months. On examination, his dyspneic, pulse 128 beats per minute, irregular. Blood pressure is 100/30 millimeter mercury. Respiratory rate 32 beats per minute. There is a diastolic thrill in the apex, mid diastolic murmur in the apical area, early diastolic murmur in the left lower external area, and systolic murmur in the aortic area. There is a lot of murmur was found in the precordium. And number one is that there is a mid diastolic murmur in the apical area. There is apical area, the mid diastolic murmur that may indicate the patient has mitral stenosis. There is an early diastolic murmur if left lower external area, and that indicates, we all know that early diastolic murmur is a feature of the aortic regurgitation, and there is systolic murmur in the aortic area. And the systolic murmur in the aortic area that all indicates the patient may have aortic stenosis, features of aortic stenosis also. That is, the patient has both aortic and mitral valve involvement. And mitral valve, this mid-diastolic murmur in the apical area indicates the patient has mitral stenosis. And there is early diastolic murmur in the left lower external area and systolic murmur in the aortic area. That is, these two murmur indicates the patient has aortic valve involvement, then patient has aortic stenosis as well as aortic regurgitation. ECG showed patient has atrial fibrillation, and chest X-ray PAV showed that is a cardiomegaly. And on echocardiogram, this is the gold standard test that reveals patient has severe mitral stenosis with moderate aortic stenosis, with severe aortic regurgitation with moderate pulmonary hypertension. So as this patient has double valve involvement and double valve disease, so the patient underwent DPR, that is double valve replacement, and he's doing well. That is, so how to learn from this case scenario, we learn from that the patient is middle age, that is a 53-year-old gentleman. So aortic regurgitation may occur in a patient, young patient, or it may occur in an elderly age group. If a patient present in the earlier age group, that is a young patient, that may indicate this patient cause of this aortic regurgitation may be due to rheumatic heart disease, or there may be some congenital causes like congenital bicuspid aortic valve, and there are some other causes. There may be some syndromes like Marfan syndrome, some other causes. There is aortic dilatation, and this aortic dilatation is associated with aortic regurgitation also. There is a valve dilatation. And if a patient present with elderly, in that cases, usually we see that it may be due to rheumatic cause, but other than rheumatic cause, there is maybe also degenerative causes. Like in elderly cases, this aortic regurgitation, there is thinning of the aortic valve occurs, and that may lead to development of the aortic regurgitation. So in that case, it may be due to the degenerative cause. And how actually a patient with aortic regurgitation may present. In that case, patient may present with shortness of breath and exertion for the last 2 years. There is, and it increases in intensity for the last 3 months. That is shortness of breath. And this shortness of breath, usually this is the most important and most frequently found presentation of a patient with valvular heart disease. It may be due to mitral valve or aortic valve or any type of valvular lesions, or it may be due to stenotic lesion, or may be due to regurgitation lesion. What may be the type of the lesion, and usually patient present with shortness of breath, and this is the commonest presentation. And along with shortness of breath, patient may present with chest discomfort or chest pain, or patient may present with palpitations also, or even patient may present with complications of the valvular heart disease like heart failure or ankle edema, or there may be ascites or swelling of the whole body that may patient have if the valvular heart disease is not treated properly or treated in time, and patient may have complications of this valvular heart disease. And on examination, patient is dyspneic. So as a patient is shortness of breath, patient may be dyspneic, and there is usually thrill. And in case of aortic agitation, usually patient has early diastolic murmur. That is early diastolic murmur in the left lower sternal area, and this is the commonest site where we can find regurgitation, aortic agitation murmur in the lower left lower sternal area, and the type is early diastolic murmur, that is diastolic murmur. And when aortic valve is only if the patient has got only aortic valve involvement, and if there is no mitral valve involvement, in that cases usually we give the treatment of aortic valve replacement, that is aortic valve change of the aortic valve. And if along with aortic valve involvement, if patient has mitral valve involvement, that is mitral stenosis or mitral regurgitation, in that cases mitral valve is also changed. So in that cases, the double valve replacement usually done if both valves are damaged. So this is the actually function of the valves. We all know that valves maintain forward flow, and there is a preventer of the reversal of the flow. As aortic valve is damaged or diseased, so patient has features of aortic agitation. These are the actually defined valves we know. We know this is the different types of valve. This is the pulmonary valve, this is the tricuspid valve, this is the aortic valve, and this is the mitral valve. The mitral valve. And this is the tricuspid valve, this is the pulmonary veins, this is the mitral valve, this is the aortic valve, this is the pulmonary valve. This is the tricuspid valve has got 3 cups, mitral valve has got 2 cups, and aortic valve and pulmonary valve has actually 3 cups. This is the pulmonary valve, this is the aortic valve, this is the tricuspid valve, this is the mitral valve actually. And this is the parts of the valves actually. This is the leaflets, this is the chorda tendineae, this is the papillary muscle. And through the papillary muscle, the chorda tendineae is attached with the ventricular wall actually. And this is actually, this is the valve types of mitral and tricuspid valve actually. So parts of the heart valve valves are annulus, commensure, chorda tendineae, and papillary muscles. So this is the abnormal valve function. There may be valve stenotic type ablation, there may be valve regurgitation type ablation, or there may be combined. What we have learned from our case today, that the patient has got both aortic stenosis, aortic agitation. So patient may have both type of lesions, that is stenotic lesion and regurgitation lesion in the same patient. And so what are the causes of valvular disorder actually? There may be congenital type of heart disease. Usually a patient with congenital cause of valve involvement, they usually present in the earlier age group. That is a younger patient below the 20 or 20 years, or maybe present with less than 30 years, or maybe present within 20 to 30 years. Rheumatic heart disease, usually with rheumatic heart disease, patient usually present after usually in the second decade, that is 10 to 20 years or 10 to 25 years. There may be infections like bacterial endocarditis, and bacterial endocarditis may cause also valve disorder. And there may be heart attack, that is damage to the heart muscle and papillary muscle. And due to heart attack, if there is a damage to the heart muscle or damage to the papillary muscle, there may be regurgitant type of ablation, especially in the mitral regurgitation. And there may be weakening of the supporting structures of the heart that lead to the development of the valvular lesions actually. And on the basis, actually types of valvular heart disease, on the basis of the duration of the dysfunction, it may be acute and chronic. This is the nature of the valvular dysfunction, that may be a stenotic or regurgitation type of lesion. And depending on the degree of dysfunction, patient may present with near degree of cardiac dysfunction. That is, patient may present with near class 1 to class 4, depending on the involvement of the valves lesions. So this is the stenotic type of lesions, that is narrowing of the valves. So there is obstruction of the flow from one chamber to the another chamber, one chamber to the next chamber actually. So there is a hindrance, or there is obstruction of the flow from the one chamber to the next chamber. And regurgitation, usually there is a leaking of the blood from the next chamber to the previous chamber. usually occurs. The regurgitation type means there is a leaking of the blood. How actually we diagnose a case of aortic regurgitation or any type of valvular heart disease? Actually, we should get a detailed history, and we should have some physical examination, and then maybe ECG may be helpful. Chest X-ray, echocardiography is the golden standard. Even invasive evaluation like cardiac cath or CT or MRI of the heart may be necessary in some cases. And there may be some other the other unknown case of heart disease. There is maybe congenital heart disease, that is bicuspid aortic valve. A patient with bicuspid aortic valve, usually patient with aortic stenosis. But in a patient with bicuspid aortic valve, patient may present with aortic regurgitation also. There may be ischemic heart disease. There may be rheumatic fever. In rheumatic fever, we all know that usually mitral valve is involved. But in some cases, as well as mitral valve, aortic valve may be also involved. That's aortic valve is the second valve, or that is usually involved in case of rheumatic fever, when you're considering the frequency of the heart valve involvement. And there is a hypertrophy or dilated cardiomyopathy, or there may be aortic diseases like Marfan syndrome or Ehlers-Danlos syndrome. In that cases, this is a connective tissue disease, and this connective tissue disease may involve the aortic valve structure, and there is aortic valve dilatation. That may be lead to the development of the development of the aortic regurgitation. And how actually patient usually present, already discussed in the our case study. Usually patient present with shortness of breath is the commonest presentation, but patient may present with heart failure, like shortness of breath or low cardiac output syndrome. Even patient may present with chest pain also, or chest discomfort. And in some cases, when there is a low output syndrome, patient may present with syncope or fatigue. Or if the patient have features of heart failure, patient may present with ankle edema or swelling of the abdomen due to ascites, and also patient may present with palpitations also. So in case of when we do physical examination, usually get there is a thrill and murmur may be found in the pericardium. There is a maybe peripheral edema if there is a features of heart failure. There may be lung crackles or the crepes in the lungs due to if there is a heart failure. There may be elevated jugular venous pressure or displaced apex beat, irregular heartbeat may be found actually. So this is the actually aortic phonogram of the aortic regurgitation actually, as this aortic regurgitation. This is a regurgitation type of murmur actually. And there is a classification of the heart murmur depending on the grading. And ECG, what findings actually we get in a patient with aortic regurgitation in the ECG. It may be normal, absolutely, that is non-specific. Even there may be features of left ventricular hypertrophy, or there may be left ventricular enlargement, or there may be left atrial enlargement, mainly mitral stenosis, but any left heart valve disease also. There is atrial fibrillation, there is a bundle branch block, or patient may present with atrial fibrillation and ectopic beats in case of aortic regurgitation. On chest X-ray, usually what we found in the chest X-ray, usually we get there is a cardiomegaly in the chest X-ray. As there is a aortic regurgitation, there is a regurgitation of the valve, so there is a volume overload over the left ventricle, and that may lead to the dilation of the left ventricle. So we get usually a dilatation of the left ventricle, that is cardiomegaly usually said. But as well as cardiomegaly, then we can also get some calcification in the aortic valve, and there may be a prosthetic valve if there is a valve replacement occurs. Following valve replacement, if we do chest X-ray, in that case we can get there is a metallic prosthetic valve also. And this is the echocardiography, that is gold standard. By echocardiography, we can confirm the diagnosis of the aortic stenosis. We can also grade the aortic regurgitation, and by grading aortic regurgitation, we can plan how the treatment actually needed in a patient with aortic regurgitation. If the aortic regurgitation is getting 3 or 4, in that cases, usually we plan for aortic valve replacement if the patient has got symptomatic. And if the patient has grade 1 or grade 2, in that cases, usually patient may remain asymptomatic, or patient may have some symptoms, but in that case, usually we give medical treatment, and in that case, medical treatment is enough to maintain the normal lifestyle, even to do with the normal lifestyle in a patient with aortic regurgitation type ablation eventually. And there may be some invasive evaluation, CT and MRI, cardiac cath may be needed to see even if we do root aortogram. In that cases, we can diagnose the severity of the aortic regurgitation as well as we can diagnose the aortic regurgitation. In some cases, CT and MRI may be needed to see the extent of the actually aortic root involvement or the dilatation of the aortic root. We can diagnosis as well as we can diagnose if there is some other findings may be present along with aortic regurgitation. So CT and MRI in some cases may be very much helpful. And these are the causes already we have discussed, and infective myocarditis may be also cause of the aortic regurgitation. And this is the pathophysiology. If there's a incomplete closure of the aortic valve that lead to the backflow of the blood to the left ventricle, there's a left ventricular hypertrophy and dilatation. There's a left-sided heart failure in the late stage, and there is a reduced cardiac output. And if there is a backflow of the blood to the left ventricle, there is increased left atrial pressure. There's the left atrium hypertrophy. There is a increased pulmonary pressure that lead to the development of the increased right ventricular pressure that may lead to the right-sided heart failure. And presentation already we have discussed. Even patient may present shortness of breath, chest pain, fatigue, and palpitations. And this is the aortic regurgitation murmur. And on physical examination, we can get some special findings if a patient has aortic regurgitation, especially there is a severe type of aortic regurgitation. Patient may have Kuhnke's sign. There is pulsation of the nail bed. We can get there is a pulsation of the nail bed. And there may Muller sign, that is pulsation of the uvula. So with every and each beat of the heart, we can get there is a pulsation of the uvula that is called Muller sign. And you can get also de-Massett sign, that is head nodding in time with the heartbeat. With every heartbeat, patient may have head nodding, that is also called de-Massett sign. Patient may have Durozier sign, that is systolic and diastolic murmurs heard over the femoral artery when it is gradually compressed with the stethoscope. So systolic and diastolic, both murmur can be heard over the femoral artery when it is gradually compressed with the stethoscope. This is Durozier sign. And patient may have Austin Flynn murmur in the, usually it found in the apex, and usually it occurs with the regurgitant jet that impinges on anterior mitral leaflet, causing it to the vibrate. And this, due to vibration, we can get the Austin Flynn murmur. This is the pulsation of the uvula. These are the master sign, head nodding with each heartbeat. And by echocardiography, you can confirm the diagnosis of the aortic regurgitation actually. And echocardiography evaluation is very much important here. And what is the management? If there is only aortic regurgitation and patient is symptomatic and patient has got grade 3 or grade 4 aortic regurgitation, in that case, aortic valve replacement is the only answer that is necessary. But if patient has aortic regurgitation as well as patient has got aortic root dilatation, in that case, aortic valve replacement along with aortic root replacement, that is artificial aortic root replacement can be done. That is called Bental's procedure, may be needed in some cases when there is a aortic regurgitation as well as there is a huge dilation of the ascending aorta. In that cases, ascending aorta is replaced as well as aortic valve is replaced. That is called Bental's procedure. And actually, when we replace the aortic valve, if there is severe aortic regurgitation and patient is symptomatic and patient has LV dilatation, there is end diastolic diameter is more than 50 millimeter, or ejection fraction is gradually decreasing like less than 55%. And if there is other indication of surgery, that is the patient has indication of coronary artery bypass surgery. So with coronary, if a patient has need coronary artery bypass surgery and also patient has got aortic regurgitation, in that cases, we will do, usually we do the coronary artery bypass graft as well as we do aortic valve replacement. And if the patient has acute severe aortic regurgitation, in that cases, aortic valve replacement is necessary. And when there is a moderate regurgitation, in that cases, if the patient has got other indication of surgery and patient has got symptoms, usually we do aortic valve replacement. And the type of surgery usually, what surgery usually we do? Usually we do aortic valve replacement, usually done, but in some, in the most cases, replacement done in the mitral aortic or tricuspid valvular valve, and in some cases, repair can be done in actually mitral valve. In that case, mitral valve replacement. And if we do aortic valve replacement by prosthetic aortic, metallic prosthetic aortic valve, there is two types of valve: metallic prosthetic valve, or that is a biological valve. In case of biological valve, usually no anticoagulant is needed. If we replace the aortic valve replacement by metallic valve, in that cases, anticoagulant is necessary. Then this is the most important cases. The important point, that is anticoagulant is necessary to prevent the thrombosis of the metallic aortic valve. To prevent the metallic aortic valve, usually we have to do give anticoagulants in a patient with aortic valve replacement. So I think this is all today, and we can stop here today. And thank you very much for giving me opportunity. So we can finish today.